Warm good morning, my dear students. So in today's session, we'll deal with a new chapter which is basically related to the different diseases which affect the bone. So you can have many varieties of diseases which is going to affect the bone. So it could be a hereditary type or a genetic type. It could be a developmental disorder. It could be related to your nutritional deficiency or hormonal change. It could be a neoplastic change, or it could be a cyst-like lesion. Basically, you have your pseudocysts like ABC and traumatic bone cyst. So all those different diseases can form the entire concept or entire group group of diseases which is going to affect the bone. And in that you have a certain type of disorder, a certain type of disease which is called as fibro-osseous lesions. And under that, there is a subcategory of disease called as fibrous dysplasia. So in today's session, we'll basically deal with what are fibro-osseous lesions, the different classifications of fibro-osseous lesions, and under that, a specific group of disease which is called as fibrous dysplasia. So this is in general the classification of different diseases which is going to affect the bone. It could be hereditary disorder, metabolic conditions, fibro-osseous lesions, neoplastic lesions, and miscellaneous conditions. So your hereditary disorders can be divided further as osteogenesis imperfecta, achondroplasia, osteopetrosis, myositis ossificans, osteoporosis, cherubism, Paget's disease. Metabolic conditions related to the hormones, that is basically thyroid and parathyroid, and also related to your nutritional deficiency, especially your vitamin D. Then another group of disorder which we call as fibro-osseous lesions, which is further subcategorized as fibrous dysplasia, cemento-osseous dysplasia, again subdivided as periapical, focal, florid, and ossifying fibroma. So all this will come under the category of fibro-osseous lesions. You can have neoplastic conditions. So neoplastic conditions, if you remember, you would have come across in different tumors affecting the connective tissue. So you can have osteoma, osteosarcoma. So these are different neoplastic changes which can happen within the bone. And certain miscellaneous conditions like aneurysmal bone cyst, traumatic bone cyst, and focal osteoporotic defect. So this is the entire classification of different diseases of bone. We'll move on to fibro-osseous lesions. So basically, what are fibro-osseous lesions? Now, fibro-osseous lesion is the replacement of normal bone by fibrous tissue. So the normal bone is getting replaced by fibrous tissue, which is composed of collagen fibers, fibroblast, and varying amounts of mineralized substance, which could be the bone or the cementum-like substance. So basically, it is where the normal bone is getting replaced by a fibrous tissue, and this fibrous tissue contains your collagen fibers, your fibroblast, and also some amount of mineralized substance, which resembles the bone or cementum. So basically, fibro-osseous, when you split, you have fibro and osseous. That means you have fibrous area plus you have osseous area. So both these together will form your fibro-osseous lesion. Now this could be a developmental change, it could be a reactive change, it could be dysplastic, it could be neoplastic. So you can have variety of reasons which will form your fibro-osseous lesion. It's a group of disease. It's not a single entity. Fibro-osseous lesions are basically a group of disease which could be a developmental disorder, or it could be a dysplastic change, or it could be even a neoplastic process. Now this is a modified WHO classification of fibro-osseous lesion. So the classification for fibro-osseous lesion which is given by WHO. Fibro-osseous lesions are further divided into fibrous dysplasia, osseous dysplasias, and ossifying fibroma. So you have three categories of disease under fibro-osseous. So fibro-osseous is further divided into fibrous dysplasia, osseous dysplasias, and ossifying fibroma. The fibrous dysplasia is further divided into monostotic, polyostotic, and craniofacial. So you have three forms: monostotic, polyostotic and craniofacial form. That is single bone, multiple bones, and the disease which is going to affect your craniofacial region. Osseous dysplasias are further divided into cemento-osseous dysplasia, which is further subdivided into periapical, focal florid, and also you have another variety called as familial gigantiform cementoma. So this is the different varieties of osseous dysplasia. And the third category under fibroosseous is ossifying fibroma. That is again further subdivided as conventional type of ossifying fibroma, juvenile trabecular type, juvenile semimatoid type of ossifying fibroma. So these are different kinds of fibroosseous lesion or the classification of fibroosseous lesions. We'll move on to fibrous dysplasia. So the definition of fibrous dysplasia basically is a benign lesion. So it's a benign disease, basically developmental in nature, characterized by the presence of fibrous connective tissue with a characteristic whorled pattern and containing trabeculae of immature non-lamellar bone. So this is what you're going to see in fibrous dysplasia. It's a benign lesion, developmental in nature, and in histology, you will see a fibrous connective tissue which is kind of arranged in a whorl pattern, and along with the fibrous tissue, that is your connective tissue, you will have trabeculae of immature non-lamellar bone, that is woven bone. Now this is basically non-hereditary of unknown cause. So the causative factor for fibrous dysplasia is not known, and it is a non-hereditary disorder. Here basically there is a defective osteoblastic differentiation and maturation. So the osteoblast is affected where there is no proper differentiation and maturation of the osteoblast. Fibrous dysplasia, as we all know, is further divided into poly, mono and craniofacial form, and your polyostotic type is further subdivided into two, that is Jaffe-Leichenstein type and McCune-Albright syndrome. So your multiple, where you have multiple bones being affected, you have further subdivision as Jaffe-Leichenstein and McCune-Albright syndrome. Now basically the craniofacial form is where you have both the maxilla and the mandible being affected. So in craniofacial variety, you have both maxilla, mandible or the entire facial skeleton being affected. And when you have multiple bones being affected, along with pigmentation, that is kefir-like spots, that is coffee with milk color. So you will have pigmentation on the body which resembles a color similar to a coffee with milk. Kefir-like, late is milk, kefe means coffee. So something which resembles that color. So you will get pigmentation on the skin, and also along with the pigmentation you will have endocrinopathies where there is hormonal change being happening, especially related to your sexual hormones. So when you have a combination of all these three, that is multiple bones is affected, you have pigmentation, and you have the endocrine system being affected. So all these three together will give rise to a subtype of fibrous dysplasia, that is McCune-Albright syndrome. So in McCune-Albright syndrome, all the three characteristics you can see. If it is Jaffe-Leichenstein type, you will have multiple bones being affected along with pigmentation. So these two together is this type. These three together is McCune-Albright syndrome. So basically it is a triad. McCune-Albright syndrome is a triad wherein you have severe multiple bones being affected or severe form of fibrous dysplasia, mainly unilateral, along with the pigmentation and endocrine. Especially you get precocious puberty in girls. In females, it's more common to the females where the puberty is going to be affected. So the pathogenesis is basically you will have mutation of GNAS1 gene, which is localized to the 20th chromosome. Now this gene codes for a protein called as G protein, which stimulates the production of cyclic monophosphate. So AMP is increased. Now increase in AMP will affect different tissues. So you will have abnormal proliferation of osteoblast, increased function of the endocrine gland, so hyperfunction of the endocrine gland, increased function of thyroid gland, precocious puberty. So these are different changes which is basically going to happen. So everything is going to increase amount of osteoblast activity, increase amount of endocrine activity, increased amount of growth hormones, hyperthyroidism and precocious puberty. You will have increased proliferation of melanocytes, and the severity of the disease, the clinical severity of the disease is going to depend upon the time of mutation of GNAS1. So if it is earlier in life, you have all the tissues being affected. That is, your melanocyte will be affected, your endocrine will be affected, your bone will be affected. So more earlier, the more effect it will have. So it will depend upon the time in which the mutation of the GNAS1 gene occurs. So early embryonic development, if the mutation occurs, it will lead to a severe form of the disease, which is basically McCune-Albright syndromes. That means you will have fibrous dysplasia, kepholoid spots of pigmentation along with endocrinopathy. If it is towards a later stage, then you will have only the fibrous dysplasia. And if it is later in life, that is in postnatal life or basically in adulthood, it is basically monostotic fibrous dysplasia. Only a single bone will be affected. So remember, the severity of the disease will depend upon the time of mutation of the GNAS1 gene. If it is too early in life, that is during the embryonic stage, then you can have all the three layers being affected. That is all the three germ layers wherein melanocytes, bone, your endocrine, everything will be affected. So if it is later, the severity of the disease is going to come down. We'll move on to the different types of fibrous dysplasia. So the first type is monostotic type, where a single bone is going to be affected. Now the prevalence rate, it is around 70 to 80%. Age is between 3 to 15 years and very common to young children. So it is more common to the young adults and children. Male and females is almost equal, and it's mainly, since it's monostotic, it is limited to a single bone. So most commonly affected area is the rib, femur, tibia, and if it is a craniofacial form, it's mainly maxilla and then humerus. So highest rate of occurrence or where it affects is the ribs. And when you compare between maxilla and mandible, maxilla is more affected than mandible. So remember, monostotic type is a less severe form. It's much more common or more prevalent, wherein you have 80% being affected. Age is between 3 to 15, more common to the children. There's no gender predilection. Single bone is going to be affected, and most common is the ribs. And if it is in the craniofacial region, it is going to be maxilla being more affected than mandible. Clinical presentation, it is usually diagnosed during the second decade and it gets stabilized by puberty. So remember, fibrous lesions or your fibrous dysplasia, by the time the growth ceases, that is, you have become matured, or the skeletal growth or the growth of the body, when it decreases or when it stops, then fibrous dysplasia also will cease or it will stop. So the disease will get stabilized by puberty. What you're going to see is basically painless swelling. So you will have swelling of that area or whichever bone is being affected, painless swelling, asymptomatic swelling. And since the bone becomes weak because it's abnormal bone deposition, the bone that is formed is by abnormal osteoblast. So it's not proper bone formation. Since the bone is not proper, it's immature, it leads to pathological fracture of bone. It's a slow growth And by the time the bone matures, or by the time the person reaches adulthood, that is where the entire body growth becomes static, then fibrous dysplasia also becomes static. So it becomes static with skeletal growth completion. Usually in monostotic type, the degree of bone deformity is very, very less, and it affects mandible. If it affects mandible, it's truly monostotic, because mandible is a single bone. It's a single bone. So that is why it is called as truly monostotic type. Maxilla has multiple bones. So when it affects a maxilla, it can involve all the adjacent bones, that is the zygoma, the occipital, the sphenoid. So you have different bones forming maxilla, while mandible is a single bone. That is why this is truly monostotic. And when it affects the maxilla, you will call it as a craniofacial type of fibrous dysplasia, because you have multiple bones being affected. Facial presentation. So when it affects your facial area or the craniofacial area, you will have facial deformity. So there will be swelling of the bone. So facial deformity will be present. The swelling is basically either labial or the buccal plate. So more commonly it affects the buccal plate. If it's mandible, you will have protuberance of the inferior border of the mandible. So this area is going to protrude out. Maxilla, when affected, it's much more severe than the mandible. It can extend to the maxillary sinus, the zygomatic process, and even the floor. So this entire area can become affected. And within the oral cavity, when the jaw swells, you can have malalignment of the teeth, tipping of the teeth, displacement of the teeth, some amount of tenderness. And when you observe, the mucosa over the lesion will be intact. So mucosa won't be affected. It is the bone which is going to swell up. So you can have swelling, which is basically less tender, or you have asymptomatic bone swelling. And if it's maxilla, it's going to be much more severe, because multiple bones can be affected. Within the oral cavity, you can have malalignment, tipping, and displacement of the teeth. When you look at the radiographic presentations, it usually has a variable appearance. It can vary from a small unilocular to a large multilocular radiolucency. So it can be a small unilocular radiolucency to a large multilocular radiolucency, which is well circumscribed. So it has a well circumscribed border, and within the radiolucent area you can see fine network of fine bony trabeculae. And there is another sign which is called as a rint sign. So rint sign is where you have the radiolucency with a sclerotic border. So if you observe here, you can see the sclerotic border, a dense border surrounding the radiolucent area. So this is called as a rint sign. That is, the radiolucent area is going to be surrounded by a sclerotic border. Sometimes you can have another appearance which we call as a mottled appearance. So you can have a complete radiolucency, or you can have a mottled appearance. The mottled appearance is you will have radiolucency along with radio opacity. That is because of increase in the amount of bone deposition or increased trabeculation. So when you have more number of trabeculations, you will have radio opacity within the radiolucent area. The next variety of radiographic presentation is called as a ground glass appearance or peau d'orange. So ground glass appearance or peau d'orange, it looks like as if the glass is being ground, or it resembles the surface of an orange peel. So the surface of an orange peel, that is called as a peau d'orange. So you can have an appearance like that where you have radio opacities. So you can have delicate trabeculae. It won't be as well circumscribed as this what we had discussed before, and it's going to blend into the adjacent bone. So in a ground glass appearance or a peau d'orange appearance is radio opacity, wherein you have delicate trabeculae. It does not have a well circumscribed bone, and the border merges with the normal bone which is adjacent to it. The other features which you can see is thinning and expansion of the cortical plates, and also you can have bulging of the lower border of the mandible. So this is basically what you're going to see. So it's a variable appearance. You can have radiolucencies, you can have a mottled appearance, or you can have a ground glass appearance. So three appearances, And you can see a rint sign in case if it is a properly radiolucent area. You will see a radiolucent area with a sclerotic border, which we called as a rint sign. Other radiographic findings which can be seen is displacement of the inferior alveolar canal. So this is seen towards the mandible. The inferior alveolar canal will get displaced upwards. The periodontal ligament space is going to narrow down. Lamina dura becomes blurred or it becomes ill-defined, and it's going to blend with the adjacent bone. So this is the other feature which you can see. PDL space is going to narrow down. Lamina dura is going to blend with the adjacent bone. So you don't see a specific lamina dura there. When it affects the maxillary region, it can extend into the maxillary sinus, leading to obliteration of the maxillary sinus. The other feature when affecting the craniofacial area is you can see increased density in the base of the skull. So the base of the skull becomes really dense, especially in the occiput, sphenoid, roof of the orbit and the frontal bone. So when you see an increased density at the base and all these bones are affected, then we call it as a fibrous dysplasia of the skull. So when you see a feature like this where there is increased density in the base of the skull, it's called as a fibrous dysplasia of the skull, wherein all these bones are going to be affected. The other type which we can get is a polyostotic fibrous dysplasia, wherein multiple bones are going to be affected. So the prevalence rate is less, it's between 20 to 30%. Now the age group here is before the age of 10 years and it is symptomatic. So 2/3 of the patients are going to be symptomatic, while your monostotic is mainly asymptomatic. It involves more than 2 or more bones. The common area where it affects is the skull, facial bone, pelvis, spine and the shoulder girdle. The other sites include femur, tibia, ribs, upper extremities and the lumbar spine area. This could be unilateral or it could be bilateral. Usually monostotic is unilateral. If it is polyostotic, it can be either way. So the most common area which is going to be affected is your facial area. While in monostotic, the most common area is the rib. When you look at the clinical presentation, like we said, 2/3 of the patient is more symptomatic before the age of 10 years. So when it occurs before the age of 10 years, they are usually symptomatic. That means they will have pain or tenderness. So pain in the limb area. So mainly the limbs are going to be affected and you can have pain there. There will be limping because the bone that is developed in your limbs are not proper. So the leg discrepancy is there. One leg will be shorter than the other. So you can have limping. Bone that is formed is not good quality bone. So there will be fracture of the bone. Bowing of legs can occur because the bone that is present on your legs is not good bone. So there will be the weight bearing area, the weight which falls on your feet is going to bend your leg. So the integrity of the bone is lost and it will lead to bending of the leg. The other appearance which we can get is something called as the hockey stick appearance, or otherwise called as a shepherd's crook. So it will bend, the bone can bend like your shepherd crook. So if you look at here, especially your femur area, you can see it is bent. That is because of the weight which falls on the bone, and the bone is not a solid bone. So it will bend like this. That's called as a shepherd's crook, because you can have curvature of the femoral neck and the proximal shaft of the femur. So this is what you see. And also you will have overgrowth of your soft tissue. So the soft tissues, because remember the bone area is going to be replaced by the fibrous tissue. So more of connective tissue will be seen. Length discrepancy can lead to involvement of the upper portion of the femur. So this we had discussed along with the shepherd's crook. So it will bend and it will give you a hockey stick deformity or a shepherd crook like appearance. So other than the bone being affected, so within the bone, remember you can have fracture, you can have swelling, pain, length discrepancy, and it can bend and form your shepherd crook appearance or your hockey stick appearance. So other than the bone, the next area to be affected is the melanocytes. So you can have pigmentation which we call as a kephiolyte pigmentation, and it's usually unilateral, and you get a brown color or a tan color pigment macule on the trunk and the thighs. So this is a common area to be affected. Either on the trunk or the thighs you will get a brown color pigmentation like this, and the margins of this pigmentation is very irregular. That is why it's called as a coastline of mane. So it resembles a coastline of mane. Now you can see kephiolyte spots in another disease, basically your neurofibromatosis. In neurofibromatosis, the margins are very smooth. So you can get a pigmentation like this in neurofibromatosis, but the margins are going to be smooth, which resembles your coastline of California. So that is coastline of California. The pigmentation which you see in fibrous dysplasia resembles a coastline of Maine. And usually the pigmentation is going to precede the development of skeletal and endocrine abnormalities. So what comes first in a polyostotic type is basically the pigmentation first, followed by the skeletal abnormality, and then followed by the endocrine abnormality. So what appears first is a pigmentation. Then the subtypes of polyostotic, this we had already discussed. You have two types, that is Jaffe-Leichenstein type and McCune-Albright syndrome. So in Jaffe-Leichenstein, we have fibrous dysplasia along with kephiolyte spots. It's only two, fibrous dysplasia with pigmentation. When it is McCune-Albright syndrome, it's a severest form where you get fibrous dysplasia, pigmentation, and endocrinopathy. So triad, it's a triad. And the endocrinopathy is related to sexual precocity, pituitary adenoma, and hyperthyroidism. So you can have all these together associated with the endocrinopathy. It is a precocity, sexual precocity, adenoma of the pituitary glands, or hyperthyroidism. So McCune-Albright syndrome is a greater clinical variety wherein you have a triad. There are other syndromes which are associated with the polyostotic type. So there is a syndrome which we call as a Messer-Brod syndrome, wherein it's a rare sporadic disease which is characterized by polyostotic fibrous dysplasia along with intramuscular myxoma. So we know what is myxoma. It's a benign tumor wherein you have loosely arranged connective tissue. And it contains a lot of hyaluronic acid. That's why the tissue becomes very loosely arranged. So this is intramuscular myxoma. And the myxomas usually appear many years after the manifestation of fibrous dysplasia. So this will occur after some time. So it is tumor, a benign tumor along with fibrous dysplasia, especially multiple bones, which we call as Messer-Brod syndrome. It can change into sarcomatous transformation. So your myxoma can become a sarcoma. The other malignancies which you get associated with McCune-Albright syndrome are all this. That is, you can get osteosarcoma, you can get fibrosarcoma, chondrosarcoma, liposarcoma. So all this can be associated with McCune-Albright syndrome. The transformation usually happens as a result of radiation. So when you expose a patient to radiation or you give radiation therapy, it can turn into a sarcoma, or benign tumor will turn into a sarcoma. And usually the females are at a greater risk because there is an elevated estrogen level. So they get breast carcinoma due to a hormonal change, especially when the estrogen level gets elevated. The lab diagnosis, you can have serum alkaline phosphatase level being increased, BMR is going to be high, and also hypophosphatemia. So that is because of the renal phosphate wasting. So these are the different lab diagnoses which you can see within fibrous dysplasia. Histopathology, when you look at histopathology, what you're going to see is, remember, as per the definition, it is bone being replaced by fibrous connective tissue. So within that fibrous connective tissue, you see fibroblast, you see collagen fibers, you can see some amount of mineralized areas. It could be bone or cementum-like material. So here you will see irregularly shaped trabeculae of immature bone. So the bone that is present is woven bone or immature bone, which is arranged in a cellular, loosely arranged fibrous stroma. So if you look at this picture here, see the background. It's lots of collagen fibers with fibroblast. It's highly cellular because you have an increased amount of fibroblast. And within that connective tissue, you see bony trabeculae. So this is your bony trabeculae, which is immature, or basically it is woven bone. The trabeculae is not connected with each other. So this is a low power view. You can see the trabeculae are individual. They are not interconnected. There is no interconnecting network of trabeculae. So each trabeculae is independent. They are not connected to each other, and they have a curvy linear shape. So they have a specific shape which we call as a Chinese letter pattern. So usually they are arranged in Chinese script writing or a Chinese letter pattern. That is, you have your Chinese script. So if you look at them, they are usually curvy linear and more resembles your Chinese script. Now this bone that is present here, it usually arises by metaplastic change. So whatever bone formation happens here is originated as a result of metaplasia, and they are not surrounded by osteoblasts. You don't see osteoblastic rimming. So fibrous dysplasia, there is absence of osteoblastic rimming. And this is more of a monotonous pattern. So if you observe, it is a uniform monotonous pattern. And at the border, it fuses directly with the normal bone without any line of demarcation. So border, normal bone and lesional tissue are merged together. And later on, they can undergo progressive maturation. So remember, in histopathology, immature trabeculae of bone, which is arranged in a cellular, loosely fibrous stroma. Trabeculae is not connected to each other, and they usually have a curvy linear type or structure, which we call as a Chinese letter pattern or Chinese script writing. The bone that is formed within the cellular stroma is as a result of metaplasia. There is no peripheral rimming of osteoblasts. So if you take one woven bone, there is no rimming of the osteoblast. There is no osteoblast on the periphery of this woven bone. It's more of a monotonous pattern. There is no distinction between the lesional tissue and the normal bone because it's all merged, and with time it will undergo maturation. So by the time the person acquires skeletal maturity, this sort of fibrous dysplasia will cease the growth. So fibrous dysplasia is only present during the growing age of the patient. And once a patient matures, that is the person attains skeletal maturity, the lesion also will stop growing. So in treatment, if there is a facial deformity or asymmetry, surgical recession has to be done. Usually the disease will stabilize and stop enlarging when the skeletal maturity is reached. Some patients, you can have regrowth of the lesion, that is around in 25 to 50% of the cases, especially in younger patients, and the patient can be put on a bisphosphonate therapy. So the treatment that can be done is either resection or you can give bisphosphonate therapy. So the question for this session, it's usually an essay question which is asked. So the question is classify fibrous lesion. So wherein you divide or you give the classification of modified WHO type, where you have your fibrous dysplasia, your cementitious lesions, osseous dysplasia and ossifying fibroma and the various subtypes of it, and discuss in detail fibrous dysplasia. So under fibrous dysplasia, you have to define it. What is the pathogenesis? That is mutation of GNAS1 gene, wherein there is increased G protein expression. Cyclic AMP is increased, and when cyclic AMP is increased, you have increased proliferation of all the three germ layers, that is your endocrine, your that is the bone formation, abnormal osteoblast and melanocytes are increased. The different clinical features, especially your monostotic type, polyostotic and polyostotic, which is further divided into Jaffe-Lakenstein and your McEwen-Albright syndrome. What are the features? how is it being affected, and also the syndrome that is associated, the other syndrome that is associated with polyosteotic, that is Mesebrod syndrome. Lab diagnosis, and finally the histopathology and the treatment. So this is an essay question which is usually asked from this chapter. Thank you and have a good day.